morning. I'm Dr. Vijaya Lakshmi from OBG department. Today I'm going to teach you about Puerperium. What is Puerperium? It is in this class I would like to teach you about normal Puerperium. In next class I will teach you about abnormal Puerperium. So what is Puerperium? Puerperium is the period following childbirth during which the body tissues, especially pelvic organs, revert back to the pre-pregnant state, both anatomically and physiologically. There are a lot of changes occur in pregnancy. So both anatomical changes and physiological changes. So the time period required to come back to the normal state is called puerperium. Usually it will be takes 6 weeks. Depending on the time period of changes, puerperium is divided into 3 stages: the immediate puerperium, the early puerperium, the remote puerperium. The immediate puerperium is the first 24 hours, which most of the changes, sudden changes occur. So that is the most crucial period. That's why first 24 hours is very important for any pregnant lady after delivery. Either it is normal delivery or cesarean section. She should be in observation for first 24 hours. So under close supervision. Because this is the stage of acute post-anesthetic or post-delivery complications may occur. The next stage is early puerperium, which extend until the first week of postpartum. The drastic sudden changes occurs in first 24 hours. Majority of the changes occurs in first week. Some changes, 80% of the changes will be completed by first week. The remote puerperium is, which is a period up to the remaining from first week to 6 weeks, where the period of time required for evolution of genital organs, because it takes a long time to come to the normal stage. That is the remote puerperium. What occurs in the puerperium? It is uterine involution. During pregnancy, uterus undergoes hypertrophy. Uterine muscle fibers undergoes hypertrophy and hyperplasia. There are a lot of enlargement, a lot of marked increase in size and weight during pregnancy, which is approximately 10 times to the normal pregnant weight. That is about 1,000 grams. But involutes rapidly after delivery. Once the baby comes out, the uterus contracts to the cricket ball consistency, which is firm and hard. Immediate after delivery, the uterus weighs approximately 1 kg. And its size is of 20-week pregnant at the level of umbilicus. Though it is non-pregnant uterus, it is in the pelvis. Immediate after delivery, it immediately won't come to the normal stage. It takes, because it is at the 36 weeks to, it comes to 36 weeks to 20 week size because of contraction. At the end of the first postpartum week, normally decreases to the size of 12-week gestation. Uterine involution is nearly complete by 6 weeks, almost similar to the non-pregnant state, and weighs about 60 grams. So this is immediately after delivery. That is first day of delivery at the umbilicus, and the second day of delivery at 18 weeks, at third day 16 weeks. Like that, slowly it reduces the size, it contracts and reduces the size. Reduces size, and on 10th day it will be at the symphysis pubis level. So that is the uterine involution. That is the upper segment. What we spoke until now is about the upper segment. Lower uterine segment, it reverts back to the normal shape and size of the isthmus in few weeks. And cervix. The cervix contracts very slowly. The contour of the cervix takes a long time to regain, that is approximately 6 weeks. But the external os never comes to the nulliparous state. Nulliparous os is pin-size hole, but external os is pin-size. But in parous women, once the delivery occurs, that os is patulous. The physiological process of involution. Muscles. The number of muscle fibers is not decreased. During pregnancy, muscle fibers increase in number and size. That is hypertrophy and hyperplasia occurs. But during involution, the number of fibers not decreased. But there is a substantial reduction of the myometrial cell size. Blood vessels. Cells are more pronounced at placental site. at placental site. Arteries undergo thrombosis, hyalinization, and endophlebitis. New blood vessels grow inside the thrombi. Endometrium. Following delivery, decidua is cast off. Endometrium is left behind is very thin. Once the delivery occurs, along with the placenta, all the decidua is cast off. Endometrium is 2 to 5 mm thickness. Regeneration starts by 7th day, but completed by 10th day, and the entire endometrium is restored by the 16th day. That is, by 16 days, the endometrium full thickness. But at the placental site, it won't regenerate immediately. It takes about 6 weeks. And involution of the other pelvic structures. Vagina. It regains its tone in 4 to 8 weeks, but never to vaginal state. So, the rugae and the tone are different in the nulliparous. Once delivered, it won't never regains its virgin state. Rugae partially reappear at 3rd week, but never to the same degree as in the pre-pregnant state. The introitus remain permanently larger than the vaginal state. Hymen is lacellated and represented by nodular tags, the carunculum multiformis. And about the involution of broad ligaments and round ligaments, it also recovers slowly from the stretching and laxation. And pelvic floor and pelvic fascia also takes a long time to involute after the parturition. About the lochia, lochia is the vaginal discharge from the vaginal discharge for the first 14 days during the puerperium. Depending upon the variation in color change, lochia is categorized into three categories: lochia rubra, lochia serosa, and lochia alba. Lochia rubra is red in color. That is the discharge from the vagina in the first 4 days after delivery. It consists of blood, fetal membranes, and decidua. Vernix caseosa, lanugo, and meconium. Vernix caseosa, lanugo, and meconium are the fetal body surface from the fetus. So that consists of both most of the fetal parts, fetal origin. The first 4 days is the red color, and next after 4 days, 5 to 9 days, that is lochia serosa. That discharge is yellowish or pinkish or pale brownish. It consists of less RPC, leukocyte, that is mild inflammatory. Mild inflammation occurs and wound exudate mucus from the cervix and microorganisms, anaerobic streptococci and staphylococci. And after 9 days, that is from 10 to 15 days, that is the last week, is lochia alba, that is pale white. It consists of plenty of decidual cells, leukocytes, mucus, cholesterol crystals, fatty and granular epithelial cells, and microorganisms. General physiological changes. What occurs after delivery? Immediately after delivery, the pulse rate is very high, rises to very high level, and which settles down to normal on 2nd day. That's why first 24 hours very crucial. We have to observe very carefully. Temperature. The rise of temperature immediately after delivery. That is some pyrite. We can notice there is a rise of temperature in almost every woman immediately after delivery, but comes down to normal within 12 hours. Urinary tract. The bladder mucosa becomes edematous and hyperemic, and the bladder capacity is increased, and the bladder may be over-distended, incomplete emptying, urinary stasis, and risk of UTI is high. And dilated ureters and renal pelvis return to normal size within 8 weeks. Pronounced diuresis on the 2nd or 3rd day of the puerperium occurs. What about the changes in gastrointestinal tract? Immediately after delivery, there is an increased thirst in the early puerperium is due to loss of fluid during labor in the lochia and diuresis and perspiration. And constipation is the most common problem immediately after delivery. That is due to delayed GI motility and mild ileus following delivery, together with perineal discomfort due to episiotomy and lacerations. Patient is not able to move, and that's why there is decreased motility. Constipation is the most common complication. Weight loss. Weight loss mainly weight loss immediately after delivery is due to the expulsion of the placenta and fetus. lighter, and blood loss. That is 5 to 6 kgs. Usually, the antenatal mother gains weight during pregnancy 12 to 15 kgs, but immediate loss of weight is only 5 to 6 kgs. That is due to fetus and placenta, lighter, and blood loss. But weight loss is due to diuresis is 2 kgs. The weight loss may continue up to 6 months after delivery. Whatever she gained the weight during pregnancy, it takes 6 months, at least 6 months to lose the weight and to come to the normal weight. And fluid losses. What about the fluid losses? At least 2 liters during the first week, 1.5 liters during the next 5 weeks. The amount of loss depends on the amount of retained during pregnancy. She gained so much weight due to physiological changes. She gained so much weight. She has to lose the weight. The 5 to 6 kgs is fetus and placenta. And the diuresis, that is some kind of what lost due to diuresis. And the amount of whatever she gained during pregnancy, she has to lose it due to the changes and hemostasis. All these changes occurs. It takes some time, and it takes at least 6 weeks. Loss is more in women with preeclampsia and eclampsia. Blood values. Immediately following delivery, there is a slight decrease in blood volume due to blood loss and dehydration. Blood volume returns to non-pregnant level by second week. Cardiac output rises soon after delivery to about 80% of pre-labor value, but returns to normal level within 1 week. RBC volume and hematocrit values return to normal by 8 weeks postpartum. This is the graph showing what the changes of cardiac output, total blood volume, blood parameters during the pregnancy and the immediate postpartum. That is, at the term, RBC volume is increased, plasma volume, total blood volume, cardiac output, they are at the peak. During the delivery also, they are highest level. Immediately after delivery, they start falling down. But to come back to normal, it takes 6 months. But in the first 2 weeks, majority almost not the complete normal, near normal state. It takes near normal for 2 weeks. Leukocytosis is, that is 25 blood count, WBC count is 25,000 per cubic mm occur following delivery in response to stress of labor. Platelet count decreases soon after separation of the placenta, but secondary elevation occurs between 4 to 10 days. Fibrinogen levels remain high up to second week. Hypercoagulable state persists for 48 hours postpartum, and fibrinolytic activity is enhanced in first 4 days. Second rise in fibrinogen, factor 8 and platelets in the first week increase the risk of thrombosis. Increase in fibrinolytic activity after delivery acts as a protective mechanism. Menstruation and ovulation. What about the menstruation and ovulation after delivery? The onset of first menstrual period following delivery is variable and depending on the lactation. In non-lactating mother, ovulation may occur as early as 4 weeks. Menstruation returns in 6 weeks in 40% and by 12 weeks in 80% of the cases. If mother is not lactating, only the 3 months. The maximum period she won't get periods is only 12 weeks, that is 3 months. A woman who is exclusively breastfeeding, the contraceptive protection is about 98% up to 6 months postpartum. Non-lactating mothers should use contraceptive measures in 3rd postpartum week. Lactating mothers should use contraceptive measures in 3rd postpartum month. This is the scheme of mechanism of amenorrhea and anovulation lactating mothers. Due to breastfeeding, increased prolactin level is increased. The prolactin increases negative feedback on the hypothalamus. So it inhibits the ovarian response to FSH, suppresses the release of luteinizing hormone, decreases the GnRH secretion. When it has negative feedback inhibition on FSH and LH, on FSH there is less follicular growth. Less follicular growth means there is no estrogenic state, no menstruation. So there is no chance of the endometrial proliferation, the proliferative phase and secretory phase, these are not there. Due to suppression of LH, there is no LH surge, there is no ovulation. Here, because of FSH inhibition, there is no follicular growth. Even the follicle grows LH suppressed, there is no LH means ovulation doesn't occur. That means amenorrhea. In combined response is amenorrhea. That is, this is the mechanism of how breastfeeding inhibits menstruation. That is amenorrhea, lactational amenorrhea, and ovulation in lactating mothers. This is the prolactinism plays the main role here. Lactation. Coming to the lactation. So once the delivery is done, the first 2 days following the delivery, no further anatomical changes in the breast occur. The secretion from the breast called colostrum, which starts during pregnancy, becomes more abundant during the period. It is deep. What is a colostrum? It is a deep yellow serous fluid, alkaline in reaction. It has got a higher specific gravity, high protein, vitamin A, sodium and chloride content, but has got lower carbohydrate, fat and potassium than the breast milk. It contains IgA antibody produced locally. So what are the advantages of colostrum? The colostrum contains antibodies because the immune system is immature in newborn. So the infant needs antibodies to fight against the infections. So these are, colostrum has the antibodies IgA, IgG, IgM and humoral factor lactoferrin provides immunological defense to the newborn. And moreover, the colostrum has laxative effect and it's a laxative action on the baby because of large fat globules in the colostrum. Coming to the physiology of lactation. The physiological basis of lactation is divided into 4 phases: mammogenesis, lactogenesis, galactokinesis, galactopoiesis. So coming to the mammogenesis. Mammogenesis is the preparation of breast. Pregnancy, from the beginning of the pregnancy, the preparation of breast starts. Pregnancy is associated with a remarkable growth of both the ductal and lobular system because of the hormones. There is a remarkable growth. And the secretion of milk, that is colostrum, starts from the beginning of the pregnancy. But it is inhibited due to the estrogen and progesterone. So in the pregnancy, there is no milk secretion, even though breasts are prepared for the feeding. Next one is lactogenesis. Lactogenesis is the synthesis and secretion from the breast alveoli. Some secretion is evident, that is colostrum, during pregnancy. Accelerated by following delivery, milk secretion actually starts on 3rd or 4th postpartum day. In spite of high levels of prolactin during pregnancy, estrogen and progesterone make breast tissue unresponsive to prolactin. Following delivery, where the estrogen and progesterone levels fall down, then prolactin begins its milk secretory activity. Prolactin and glucocorticoids are the important hormones at this stage. Secretory activity is enhanced by growth hormone and thyroxine and insulin. Galactokinesis. Galactokinesis is ejection of milk. Oxytocin is the major galactokinetic hormone. Discharge of milk from the mammary gland of breast depends upon the suction exerted by the baby during the suckling. Contractile mechanism also plays an expression of milk from the alveoli into the ducts. During suckling, a conditioned reflex called suckling reflex is set up. Oxytocin is liberated from the posterior pituitary, produces contraction of the myoepithelial cells of the alveoli and the ducts containing the milk. This is called milk ejection reflex or milk let down reflex. We'll see in detail about how the milk ejection reflex and suckling reflex they are coordinate. Milk ejection reflex is inhibited by pain, breast engorgement, and adverse psychic condition. Here is the reflex arc showing the role of prolactin and oxytocin in reflex milk ejection reflex. Here, on baby's hunger, on baby's cry, it acts on mother emotional. It acts on hypothalamus. It stimulates mother's hypothalamus. Hypothalamus sends impulse to the posterior pituitary. The posterior pituitary secretes oxytocin, and the anterior pituitary secretes prolactin. Prolactin is important for the milk secretion, but oxytocin is important for squeezing of the muscles, muscle contraction and ejection. For the ejection, for the production, oxytocin is responsible. For ejection, oxytocin is responsible. So once the oxytocin is released, milk ejection occurs. It is coordinated with suckling. So once the baby suckling starts, and it is the cycle repeats. This is how suckling and milk ejection reflex coordinate. Galactopoiesis. Galactopoiesis is the maintenance of lactation. Prolactin appears to be the single most important factor for maintenance of lactation. Yeah, so prolactin is called as galactopoietic hormone. Suckling is essential for maintenance of lactation. Suckling is essential for the removal of milk from the glands in the breast and also for the release of the prolactin. Secretion of milk is a continuous process unless suppressed by congestion or emotional disturbances. This is the physiology of lactation. Suckling, this is the stimulus. It sends signals to the hypothalamus. From the hypothalamus, anterior pituitary secretes prolactin, which causes the milk production. Posterior pituitary secretes the oxytocin, which results in milk ejection. This is the milk ejection reflex and milk let down reflex. Prolactin causes the production of colostrum initially. After a few days, regular milk is produced. Suckling of the baby stimulates nerves in the areola of the breast. This stimulates the pituitary to release prolactin and oxytocin. The prolactin initiates milk production and moves milk into the ducts. Oxytocin causes the weak contractions in the breast to move the milk. Oxytocin, not only for the milk production, it also causes weak contractions in the uterus to return to the uterus to its normal size and shape. Thus, breastfeeding mothers regain uterine muscle control quicker. These are the 10 good things we need to know about exclusive breastfeeding. It saves lives and protects baby against diseases with antibacterial agents. This is sterile milk. Mother's milk is more sterile. It provides all nutrients to baby needs for the first 6 months. The third thing is it ensures a clean and safe source of food, especially in emergencies. And it makes child grow strong and intelligent. It breaks the cycle of diarrhea and malnutrition, and it bonds mother and child. It reduces the mother's risk of ovarian and breast cancers, and helps spacing pregnancies and acts as a natural method of birth control. And it saves money but not having to buy infant formula and feeding equipment. It protects the environment with no need for the packaging and disposal. So exclusive means 100% breast milk, no water, no solid food, and nothing else. Coming to how to manage a puerperium. In the puerperium, there are a lot of changes occurs anatomical and physiologically. And during these changes, mother can come across different issues. So how to manage? What are the principles in the management? The principles in the management of normal puerperium is to restore the health of the mother, to prevent infection, to take care of the breast, including promotion of breastfeeding, and to motivate the mother for contraception. These are the 4 principles included in management of normal puerperium. Rest and ambulance. Good resting period followed by early ambulation after delivery is beneficial. Advantages. Provides a sense of well-being. Bladder complications and constipation are less. Facilitate uterine drainage and hastens involution of the uterus. Lessens puerperal venous thrombosis and embolism. Diet. And she is allowed to take normal diet of her choice. There is no dietary restrictions. So she can take balanced diet and healthy diet of her choice. Lactating mothers need high calories, adequate protein, fat, plenty of fluids, minerals, and vitamins. A healthy mother will produce about 500 to 800 ml of milk a day to feed her infant. This requires about 600 kilocalories per day for the mother, which must be from the diet. Non-lactating mothers, a diet is the normal calories as she was before pregnancy. That is, when she was in non-pregnant state, the amount of diet, how much is she taking? She has to take that much, not excess need. There is no need of excess calories because she is not feeding. So she doesn't need any extra calories. Care of the bladder. A patient is encouraged to pass urine as soon as convenient. If the patient fails to pass urine, catheterization should be done. Catheterization is done in incomplete emptying, and a continuous drainage is kept until the bladder tone is regained. The main thing here is ensure adequate bladder drainage to prevent infection and sinusitis and cystitis. If you don't, if the patient does not pass the urine, and in case of stasis, there is the chances of urinary tract infection and cystitis. Care of the bowel. Early ambulation to prevent the constipation. A diet containing enough fibers and balanced diet and enough fluids to prevent constipation. Pain management also important to prevent the constipation. Pain due to episodium and lacerations restrict the mobility, so it may lead to constipation. In case of constipation is not relieved with general measures, we can advise mild laxative at bedtime. Care of the vulva and episiotomy wound. The vulva and buttocks are washed with soap and water down over the anus. The perineal wound should be dressed with spirit and antiseptic powder after each act of micturition and defecation, or at least twice a day. Cold cinch baths relieve the pain. Persistent perineal pain needs vaginal and rectal examination to detect any hematoma, wound gaping, or infection. Ibuprofen is safe for nursing mothers. Care of the breasts. Nipple should be washed with sterile water before each feed, cleaned and care to dry after feed. Nipple soreness is avoided by frequent short feedings rather than prolonged feeding. Nipple confusion is where the infant accepts the artificial nipple but refuses the mother's nipple. If alternatively, some people will give alternatively mother's feeding and artificial nipple. So the infant gets confusion. So we need to avoid the artificial things. Avoid nipple confusion by making the mother nipple more protractile and not offering any supplemental fluids to the infant. The postpartum exercises. Objectives of postpartum exercises is to improve the muscle tone which are stretched during pregnancy and labor, especially the abdominal and perineal muscles. Educate about the correct posture, including the correct principle of lifting and working positions during day-to-day activities. And the common exercises prescribed are to tone up the pelvic floor muscles and to tone up the abdominal muscles and the back muscles also. Physical activity and sexual activity. Physical activity should be resumed without delay. Sexual activity may be resumed after 6 weeks when the perineum is comfortable and the bleeding has stopped. A checkup and advice on discharge. A thorough checkup of the mother and the baby is mandatory prior to the discharge. The discharge advice includes measure to improve the general health, that is what are the food, about the balanced diet, what she has to take in the diet, and the continuance of the supplementary iron therapy, and in case of any deficiencies we have to correct them, and we need to supplement with the iron, calcium and multivitamins. In case there is any excessive blood loss during delivery, we need to correct the anemia, and we have to advise accordingly during the discharge. The postnatal exercise, the patient should be taught about the exercises about the to tone up pelvic muscles, pelvic floor muscles, abdominal muscles, and general exercises, but it should not be more strenuous to her. And encourage to counsel the patient gradual return to day-to-day activities. So to encourage the mobility, so ambulation is very important. We have to teach her that pregnancy is, once the delivery is over, she is not a patient anymore. She has to do normal daily day-to-day activities, but not to take too much stress. Breastfeeding and care of the newborn. The breastfeeding, we have to advise exclusive breastfeeding for first 6 months, and care of the newborn. About the vaccination schedule, we have to give the vaccination chart and need to vaccinate the baby accordingly. And exclusive breastfeeding, and educate the breastfeeding techniques, the positioning and care of the breast, about the sore nipple, retractile nipple, we have to educate those things. Avoidance of intercourse for a reasonable period of 4 to 6 weeks. And we have to patient, there is in case of lactating mothers, it is lactational amenorrhea will be there. But anyhow, we have, because the perineum and the episiotomy wounds, these all take some time to gain to normal state. So patient is advised avoid intercourse at least 6 weeks. And in case of lactating mothers, non-lactating mothers, there is a chances of ovulation in 4 to 6 weeks. So without getting first menstrual cycle also, there is a chance of getting pregnancy. So we have to educate her in this ovulation and in the non-lactating mothers, and about the contraceptive methods. And family planning advice and guidance. In case of completed family, we have to encourage about the family different methods of temporary and permanent methods of contraception. So at any time, if she has any problems, you have to ask her to come back to us. And these are the normal things about the puerperium. And apart from this, which is not normal, is called abnormal puerperium. But in the later class, I will teach you about the abnormal puerperium. Thank you.